Okay, good evening, and welcome to our presentation of Managing Expectations in Dentistry. My name is William Melcher, and I'm the AVP of Marketing and Company Relations for the MLMIC Insurance Company. This continuing dental education program is presented to you in conjunction with the New York State Dental Association, and we thank NISDA for their assistance in bringing this presentation to you. The New York State Dental Association is an ADA CERP recognized provider. ADA CERP is a service of the American Dental Association to assist dental professionals in identifying quality providers of continuing dental education. ADA CERP does not approve or endorse individual courses or instructors, nor does it imply acceptance of credit hours by boards of dentistry. Concerns or complaints about a CE provider may be directed to the provider or to the ADA CERP at ada.org/CERP. The New York State Dental Association designates this activity for one continuing education credit. After the presentation, there will be a question and answer session, and you can post your questions in the Q&A feature on your screen. We ask that you please complete the evaluation that will be posted at the end of our presentation, and your certificates will be emailed to each of you within a few days of this program. Our presenters tonight are Deanna Miro-Altman and Nancy May Skinner. Deanna is a risk management consultant with MLMIC Insurance Company. She has experience in women's health, labor and delivery, medical surgery units, as well as home care management and quality management. Deanna has also worked as a legal nurse consultant, reviewing and analyzing medical records and malpractice claims to identify liability issues and compliance with the standards of care. Deanna is MLMIC's risk management consultant for the New York City metropolitan area. Nancy May Skinner, Esquire, is the managing attorney for the MLMIC Legal Department. Nancy practices in the areas of appellate law, malpractice defense, insurance, and healthcare law. Nancy prepares and argues cases on appeal, performs appellate reviews of malpractice cases, and analyzes the legal issues that arise in healthcare litigation. She has authored numerous articles published in the New York State Bar Association Health Law Journal, MLMIC Scope, and MLMIC Dental Scope on medical malpractice topics, appellate practice, and risk management. I hereby state that neither Deanna Miro-Altman, Nancy May Skinner, nor I have any relevant financial relationships with ineligible companies to disclose for any portion of tonight's program. With that, I turn the presentation over to Deanna.
Thank you, Bill, and thank you, Nancy. Always a pleasure to present with you. And thank everyone for joining us in managing expectations in dentistry. We know you're busy. We appreciate your time. You're probably just walking in the door. And I'm just happy to be here because I am a couple of days status post my apicoectomy. So a little sore, but I think I'm gonna manage to survive and be with you guys tonight. And I don't know, Nancy, I had hail a couple of hours ago, so I want to say, thank you for joining us on this, spring evening. But to me, I don't think spring has sprung. It's been a little nasty today. But we thank everybody else, for being here. Okay, so just, basically, we have nothing, the presentation is, for informational purposes only, and we have no financial, disclosures, as Bill said, and the statements you hear today are solely ours as presenters. And we still don't have any relevant financial relations to disclose. We always like to thank our planning committee for their assistance, in bringing the programs to you tonight. So in just under an hour, you'll be able to recognize why patients sue dentists, as well as interpret some dental malpractice claims data, and discuss risk management strategies to reduce liability in both office operations as well as the procedure chair. So the million-dollar question for the evening is, why do patients sue? Several papers published have addressed the question, and the dominant theme always seems to be, there seems to be some kind of breakdown in the patient-dentist relationship, and most often that might be manifested as unsatisfactory dentist-patient communication. Other communication problems, include things like perceptions that dentists deserted patients, or they otherwise were unavailable to them, that they even devalued patients or family views, or delivered information poorly, or even just that they failed to understand the patient's perspective. The Emergency Care Research Institute, or ECRI, put out their top 10 patient safety concerns for 2025. And the number one on the list was the risks of dismissing patient, family, and caregiver concerns. So really a good time to be talking about this tonight. Now, even though the dentist chair isn't the first thing people think of when they hear malpractice, dentists do get sued. The average dentist gets sued at least once in their career, and it's important for dentists to be prepared in the event that they do face a lawsuit. Now, fortunately, the number is relatively small compared to other specialties. But when patients are not feeling satisfied from the care they receive, they're looking for an explanation, why something happens, sorry about that. It just, they want to hold someone accountable. They sometimes are looking for compensation for the losses or their suffering. And, they don't want the same thing to happen again, or to themselves or to someone else. So it's important when you walk into every patient appointment or encounter that you keep the top risks in the back of your mind to ensure that you provide the best patient care you possibly can. So creating workflows and developing relationships with your patients, can often sidestep that threat of legal action, as much as possible. We're going to take a quick look now at some data relevant to some of these claims. Now, we broke down the root cause, and that was really probably a terrible pun, but I had to include it. Why actions are brought and the types of injuries. Here we're looking at some closed cases from 2009 to 2022. And the top procedures, we see extractions as being the most prevalent at 27%, implants at 29%, restorations at 15%, and down the line with root canals and crown placements. The top injuries, nerve damage, was the most prevalent here at 31%. Patients that needed additional treatment, 22%. A failure to heal or infection, 11% of the time. Cosmetic injuries, 7% of the time, and lacerations and burns, 4% of the time. Now, adverse dental patient outcomes rarely arise from, just one single, cause. This is contributing factors, those multi-layered issues or failures in the process of care that might have contributed to the patient outcome, the initiation of the case, or just somehow had a significant impact on the case resolution. Now, analysis of risk factors identified in this data set aids in the understanding of those processes of care and those deficiencies in most dental cases. Most cases involve more than one risk factor. And all categories here, there are multiple subcategories and intersection of more than one risk factor. And then you combine this with, say, procedural technique. And often this is what leads to claims or difficulties in defending the claims. And often, there are these many issues that lead to that one big issue that cause patients to bring a lawsuit. If we take a look at technical skill, it's most prevalent at 80% as far as contributing factors. And this most, frequently indicates the development of known complications, the dentist recognition of those complications, the responses, as well as poor procedural technique. If we jump over to behavior related, 45%, and this is your patient dissatisfaction, non-compliance with your recommended treatment plan, as well as a failure to, keep appointments timely. Clinical judgment comes in second at 66%, and that's your selection of the most appropriate procedure, your treatment, your failure, your delay in, obtaining a specialty consult or referring the patient out. And then we look at communication, and we're going to talk about communication and documentation quite a bit tonight. And that's your rapport with your patients, managing their expectations, that informed consent process, a robust informed discussion that includes, patient consent, is really key to mitigating the potential for, a potential malpractice claim, especially when it does involve a known complication. An inadequate informed consent process really fails to adequately prepare the patient for all the possible outcomes. And this in turn does fuel their dissatisfaction with the care that they do receive. Looking at documentation, that's insufficient documentation about your clinical findings, as well as your rationale for treatment, as well as those informed discussions and documentation of the discussions as well. It's never just that signature on the form. And when you put communication together, with documentation, we're right up there at 77% of the closed cases. So we're right there, close to technical skill issues. And then as we look, administrative, that's the billing and collection issues that, many patients are dissatisfied with. As we look up some additional risk factors, many of these relate to communication, the follow-up procedures, like I said, documentation, we'll say it a lot. That's all part of our risk management trifecta. Here, finger pointing or jousting involved cases is always a concern. They outpace average growth of all cases year after year, and they're most commonly noted in implant cases, and most often, in conjunction with documentation related factors. Cases that involve that finger pointing or the jousting and documentation, when it's identified as contributing factors, are 26% more expensive to resolve than, the average of all the cases. So let's take a look at, what we can do to try to mitigate some of these things. Now, Nancy and I will get more into detail with setting, expectations in both your office procedures as well as in the dental chair. Here we mentioned, once again, the risk management trifecta: communication, documentation, and follow-up. Focusing on these systems and processes, is always going to benefit you and your patients. When we look at effective communication, looking at the health literacy level of your patients, those follow-up and documentation processes that, you have in place that really can alleviate, a patient fears. We get calls all the time regarding, disruptive patients that you have. So just sometimes being able to explain, your office routine, manage those complaints, those negative reviews in a timely manner, and just right from the get-go, stating that you have, zero tolerance policy, for certain behaviors. And then what happens in the patient chair, that patient selection, the relationship that you develop, the informed consent process. Does the patient truly understand? Are they, understanding? Are you setting realistic expectations? And of course, the documentation, and documentation. Like I said, we'll say it a lot tonight. Now, effective communication is the cornerstone of the dentist-patient relationship. Patients' perceptions of dentist communication skills, may impact, patient satisfaction, as well as the potential for allegations of malpractice. A patient's ability to understand may be compounded by their fear, their pain, their stress, embarrassment, language or cultural barriers as well. Now, the following points here are utilized to help promote open communication, enhance the ability to reach an accurate diagnosis, and develop that appropriate care plan. It's important to assess the health literacy level of your patient, evaluate your educational tools, those consent forms, the instructions. It's not a one and done deal. It's an ongoing process, and updates need to be, made when appropriate. Being able to develop plans for communicating with patients with disabilities who may be hearing or sight impaired or have limited English proficiency. And always, actively, employing those listening techniques, and, just making sure that the patients have sufficient enough time to voice their concerns. You know, having a clear understanding of office operations help reduce frustrations that do lead to escalations in behavior. Make sure your patients know, your office hours, the appointment processes, medication refill plans, how telephone calls are managed, how after hours needs are addressed. And just being able to explain in real time, delays or options for rescheduling of, appointments. So clearly define that unexpected and unacceptable behavior, profanity, yelling, intimidation, threats of harm, or legal action against you or any of your staff. It's not going to be tolerated, and define consequences of those behaviors. You can put it in your new patient packet. You can have signage. You can post it on the website or social media. Just basically being able to, having your patients aware of the expectations before they come in. Now, we all know it's not just what we say, it's that unspoken word. We know that you're busy, and oftentimes you just can't spend the amount of time with the patients that you'd like to. But it's important that you're aware of what triggers your nonverbal responses. And it might be something like, that patient that's been known to be difficult in the past, they're coming back in. Unfortunately, sometimes it's the front office staff that always gets the brunt of this. So maybe they're anxious, the patient is coming back, which then in turn, makes you anxious. So just being able to recognize and correct those nonverbal cues that could be a problem. Your gestures, your posture, crossing your arms, your facial expressions and your tone of voice, and just being aware of those gestures that have, different meanings culturally. And it is the smile business, so just having that interest, that concern for what the patient is saying, and really and truly hear what they're trying to communicate with you. Now, telephone management, the failure to properly handle and document after hours telephone calls can adversely affect patient care and lead to potential liability exposure for you. Should an undocumented telephone conversation become an issue in a lawsuit, most likely the jury is going to believe the patient's recollection of it. So really the education for your staff, they are critical aspects, to your practice. They set the tone. They're the first, often the first communication the patient has with the practice. And often they're the first ones that are going to be able to identify when a patient has an urgent need or an emergent condition. So being able to support, patient confidence in the care that you're delivering and that your office is providing is so very important. And also, messaging, are these messages making it into the record? All telephone conversations between referring and consulting physicians and patients all must be documented. And having that timely communication when there is that urgent or emergent clinical finding. A successful telephone management plan, you're going to clearly define the types of calls. You're going to express the job descriptions indicating the level of patient interaction with each position or role. And you have to be cautious about the information or services that are provided by unlicensed personnel. And as this could be, an exposure to potential liability for you as well. Having those protocols in place, those parameters, educating your staff with any changes or updates as needed. A system in place to ensure that all after hours calls are responded to in a reasonable time frame, that they're documented in the record. You always want to include the patient's name, the date and time of the call, the reason for the call, specifically, putting down their symptoms or complaints. any advice or information that was provided at the time, and include if you're changing a medication or adding a medication. And if the patient's condition does warrant the prescription of a new medication, it's important that you inquire, about any medication allergies, as well as any medications they might be on presently, to look for interactions, and then documenting these things. And then, of course, the ongoing monitoring, reviewing your telephone triage decisions, the timeliness of all your referral flows, as well as, the documentation in the dental record. If you use an answering service, request those reports on a regular basis, maintain them according to the record retention schedule. Now, answering machines or voicemail systems for after hours calls are not recommended for a couple of reasons. First of all, there are no safeguards in the event of a malfunction. Patients, do not always understand that no one's going to call them back, even if it's on the message that no one's going to call them back. So they should be used as a last resort. If an answering machine or a voicemail must be used, the messages have to be brief, simple, just include that the office is now closed. If you're having an urgent dental problem, seek care at an urgent care or emergency department of their choosing. Advise them to call 911 if it is an emergency, and include, on the message how often the machine is being checked and reviewed, and when they can expect a call back. For example, they'll get a call back, say, the next business day. And just basic manners, this is for everybody, in the office, just being able to answer the call promptly, identify who you are, have that friendly greeting, be the active listener, and speak clearly in response to the patients that are calling in. And always, ask permission before, placing them on hold or transferring. And if it seems like they've been on hold for a while, checking back with them, checking on them, and let them know that someone will be with them shortly. And just taking a message if the call can't be addressed right then and there, and let them know when they can expect a call back and who's going to call them back. And you want to, document the call substance and the time that it came in. Documenting that time, the sum and substance of all the calls, the return calls, including the patient's understanding, and just having that friendly and professional closure with each call that does come into the practice. Now, language and cultural awareness, literacy, you're not speaking the same language, other communication limitations might be disabilities, hearing or sight impairments, cultural or, religious beliefs, assessing that patient's health literacy level. And it may be as simple as, asking them what's the highest grade level that they did attain, and failure to do so, can negatively, impact a patient's capacity to give consent. Cultural differences may impact, who in the family is the decision maker, regardless of whether the patient has capacity or not. And often does lead to noncompliance in your treatment plans, as well as have, a negative impact on the trusting relationship that you're trying to build. As you look at educational tools and consent forms and you're evaluating them, you want to determine the grade level at which they're written. And this allows, all written materials that are given, that they're understandable to your patient population. And it's important to be aware of our own preconceptions, incorrect labeling or assumptions, limited English proficiency, cultural awareness, must be considered as that dentist-patient relationship is established, as we prepare for these conversations, and as we develop a treatment plan or instructions for them. Using lay terminology whenever possible with patients and their families, is important. Those technical terms, have them defined with simple language. Those patient education materials, have them written in plain language, and, avoiding those, dental or medical jargon types of terms. And just providing the staff education on the availability of the resources, having those verbal instructions that are reinforced with, say, visual aids or printed materials that are easy to read and include those pictures or models and illustrations. And just consideration given to the use of non-printed materials such as videos and audio recordings, as it's indicated for that patient population. You want to avoid using family members, friends, or non-qualified staff to act as interpreters for patients. There'll be differences, and that might be, it might impact that translated message you're trying to get across. There might be those missing subtleties of the language or culture. The dental terminology may not properly be communicated. So it's important that you thoroughly document all services or tools that you used when communicating with these patients, as well as documenting, their understanding of what you're trying to get across to them. Once again, the risk management trifecta, we talk about follow-up. It must be an integral part in your practice. And when it isn't, there's a potential for a delay in diagnosis. Results of vital tests or procedures can be lost or overlooked, and this may leave you open to exposure for claims. Potential delays in diagnosis or failures to diagnose, say, an oral cancer are the most expensive claims. Uh-oh, somebody's skipping me. So it's important. We recommend that you implement, a follow-up or tickler system in your practice and ensure that patients, the test results, the consults have been completed and that the results are received and flagged for review. And this is going to be the place where you get, to reinforce the role of your staff members. They're most likely going to be the ones flagging the results for you. You need to build time into your day to review those results, to call the patients, to respond to the questions. And your staff should be empowered to make sure that you're able to do all these things. And that's not always easy for them. So anything you can do to, let your staff know that you appreciate, the reminders to do these things is always a big help. Again, documentation, the calls, the discussions, the recommendations in the record, and, include telephone, or electronic communication in that, document all attempts to reach the patient, the facility or the consulting provider is a must. Well, I think I talked quite a bit. I think it's a good time to turn it over to Nancy. She'll get more into the importance of documentation, the disruptive behavior that patients sometimes exhibit, as well as the risk mitigation in the procedure chair. Nancy?
Thanks, Deanna. So yeah, I'm gonna be talking about some of the same risks that Deanna's been speaking with you about, but more in how do they impact the legal aspects. So both in terms of avoiding dental malpractice lawsuits and how they'll play in the event that there is a dental malpractice lawsuit. So documentation, as Deanna said, we're going to talk about it all night because it really is your most persuasive and credible proof if you're ever facing a dental malpractice case. It's made before the lawsuit, before controversy, before an adverse outcome, so it has credibility. It is something that travels with the jury into the deliberation room after, when a case is being decided. So unlike witnesses that they listen to and then they have to recall when they're in the deliberation room, they're actually going to have your chart. So if you've told a great black and white story that explains why you did what you did and how it was appropriate, that's your best defense right there. So, when you're creating that story, make sure that you're keeping it factual, you're documenting thoroughly, you're objective, it's timely. The longer the gap between when you care for a patient and when that's documented, the less credibility that document will have. And, as Deanna said, you want to make sure that the record indicates if there was an interpreter used and who that interpreter was. So the dental record is a legal document. And by that, I mean, if you don't keep an appropriate dental record for the treatment, it can be professional misconduct as well as medical malpractice. So number one, to have a really great dental record. It's also communication with subsequent providers. So it tells them what you saw, what the patient's condition was when you saw them, and the treatment that you provided. It's also communication with the patient in this day and age of patient portals. Patients are looking at what you wrote. That's important to keep in mind when you're documenting their record. Again, like Deanna said, it's important to document those telephone calls and emails. Things that happen between office visits are the things that seem to get lost, and they're also a real point of dental malpractice cases because it's something that didn't get in there. And then the patient says, I called, and then, there's a question of, cell phone records and what was said and what was done. It's important to say a call was received on this time. It was returned on this time. This was the substance of what was said in that return call and how it was handled and any follow-up care. So there is a strong correlation between patient satisfaction and dental malpractice risk. There's also a big correlation between disruptive behavior on the part of the patient and dental malpractice risk. So pay attention to what's happening in your office, how your patients are responding to you and your team, both in the office and outside the office. If you're on social media, what are they saying on social media? That's important to know as well. Patient complaints often do foreshadow litigation. So patient complaints can come in all different forms. They can come through a third party, like the Department of Education. They can come through your patient's healthcare insurance, where they're making complaints and saying they don't want to pay for something. They can come directly from the patient at an office visit, in a letter. They can make a request for a refund, one of the most common ways that a patient is dissatisfied. So have a point person who addresses all patient complaints. That's a good way to make sure that responses to patient complaints are timely and consistent. All the staff should know who that person is. And if there are patient complaints that are in writing and you need to respond to in writing, call MLMIC because we're available to you to help you create that appropriate response to the patient complaint and make sure that it doesn't have any negative ramifications. Speaking of MLMIC, we're here to help. You got a lot of great advice already from Deanna, and I hope you're going to get some good legal advice from me. But that's between us. When you call MLMIC and speak with an attorney, with a risk management consultant, don't put that in the medical record. That's not part of the patient's care, and it's not appropriate to put it in the medical record, and you don't want anybody to see it. And when they make a medical records request, if it's in there, you are going to have to disclose it. So make sure that that's not contained in the medical record. If a patient complaint arises from a clinical situation and needs clinical understanding to respond, make sure that there's a clinician involved in responding to that complaint. Maybe a dentist, maybe the hygienist who treated the patient. And make sure those responses are professional, factual, and concise. You don't want to get into, matching wits with an angry patient. Since COVID, we find ourselves in an environment with anger being higher, anger's up, demands for refunds are up, and that anger and dissatisfaction can easily escalate. So advanced planning for how, advanced planning for how you can respond to that is one good way to make sure that your patients, let's see if I can back there we go, advanced planning so that you're not dealing with a difficult patient and also dealing with what do we do now. So if your patient knows or your staff knows exactly, this is how we're going to handle it if we have a difficult patient, then you're in a much better position when and if that happens. Difficult patients may be hard to treat. A patient who's complaining and nasty while getting a cleaning may encourage one of your hygienists to do it a little faster or not want to deal with that patient again. So it's important to be aware of how patients' conduct is impacting your team. It's also a challenging time to find employees and retain employees, frankly. So how are, disruptive patients impacting your team? That's an important thing to think about. Is it leading to burnout? Address patient behavior if it is impacting your team. Let them know that there are consequences to their behavior and they will be discharged if they can't change their conduct. You may have to discharge them if they aren't willing to respond to your request for a difference. So managing disrespectful or disruptive behavior is best done preventatively. So if you can take some preventative measures to show what your expectations are, then we can hope that your patients will respond and you won't have to deal with the disruptive patient. We always recommend posting a code of conduct. Have it in your waiting room. Have it as soon as they come in. There's a zero tolerance. And whatever it is that you want to put in your code of conduct, whether it's bad language, raised voices, angry conduct, disrespectful conduct, it will not be tolerated. Be clear on the consequences for violation of that conduct. And this goes both for patients and for family members. We've had cases where it was the family member that was being disrespectful to the staff or the treating dentist. And if that's the case, then that person can be told they can't come to the office anymore. If it's a patient, then they can be told that if it doesn't change, they're going to be discharged and be in a position of having to find a new provider. If you find a patient is sort of on the edge and you want to do something to maybe, encourage their behavior to change, you can print out a copy of your code of conduct with a signature line, go through it with them, or have someone from your team go through it with them and then have them sign it. So there's no way that they can say they didn't see it or didn't understand that it was appropriate. And if a patient makes one of your team uncomfortable, a chaperone in the room or an open door is always a practical option. Managing anger inside and outside the office is important. So one way we see anger being manifested more and more regularly is with negative online reviews. And the difference between you and the patient is that you have HIPAA obligations that they don't have. A patient can put anything they want out on the internet because they can choose to waive their confidentiality. You can't. So you can't acknowledge that someone's a patient online. You can't talk about their treatment or how well you serve them in their dental care. So really the best response to an online review is no response, no public response. If you just feel like you have to give some kind of response, take the highway or the high ground and just do a simple, safe response that says, we try very hard to give the best care. We are very responsive to our patients, but we can't speak about a specific case online. If you have questions or concerns, please contact us directly. You haven't acknowledged that that person's a patient. You haven't said anything critical. So anybody who reads it who's not involved in this situation will think that's a great dentist who's taking care of their patients. And the patient will know that what they need to do is respond to you in a more personal, private way. So how do you respond? Respond in a private way with a phone call, an office visit, maybe ask them to come in to talk about the situation, not on social media, not on an online review, in a situation where there's no, PHI concerns and where you can really get to the root of the problem. There's that joke Deanna had. So if the dentist-patient relationship can't be recovered, you may need to discharge the patient because an angry patient is not a patient that is easy to treat going forward. If it's a safety issue, if the patient is threatening you or your staff, you have legal remedies. Call MLMIC. We're happy to talk to you about those legal remedies, but they certainly include contacting the police, a restraining order, or even pressing charges under certain circumstances. So next I'm going to switch gears and talk a little bit more specifically about dental malpractice and starting with the elements of a dental malpractice case. So the first is a duty, and that's a duty of care. And without a duty, there is no dental malpractice because you only have a malpractice if there is a duty. The duty typically starts with an office visit when you establish that dentist-patient relationship. But it can be other ways. It can be a consult. It can be a colleague of yours that calls and gets your advice and then tells their patient that they're relying on your advice. That has been held to create a duty. So once that's established, that duty, you have a duty of reasonable dental care to that patient. And you also can't abandon that patient in the midst of caring for that patient. The second element is a standard of care. Let's see if I can get this. Oh, there it was. No, went the wrong way there. There we go. A standard of care. So the standard you're judged by in a dental malpractice case is established by other dentists in your community. It evolves with technology and changes in the practice, but that's the standard by which a dental malpractice case is evaluated. One of the things that you need to be cognizant of is that your standard of care is based on other dentists. If you decide to send the patient to a specialist, that specialist will be evaluated by a specialty standard of care. So if you choose to do specialty work in your practice, you might be judged by that specialist standard of care. So it's just something to keep in mind when you're making a determination about referrals. The next element is a breach or a departure, or oftentimes known as a deviation in the law from the standard of care. So this requires expert proof, meaning another dentist to come in and say that your care complied with the standard of care. If it was a plaintiff, they would have an expert come in and say that the care did not comply with the standard of care. If the plaintiff doesn't have an expert or they don't bring one to trial, the case will be dismissed generally because it does require that expert proof. In dental malpractice cases, it's oftentimes the case that there's negligence or breach by more than one person alleged. So it could be the dentist who's named as a defendant. It could be other dentists who had intervening treatment, who treated before or after you, or it could be the patient themselves who's been negligent in not following advice or skipping appointments. The final element is proximate cause. And that's approximately caused injury. It means that but for your care, there would not have been injury. And the patient must prove that your treatment caused that injury. Defenses that you might have on proximate cause would be, regardless of what happened in the care here, what the patient is saying happened was a pre-existing condition, say, for example, decay. So how do you prove that there was no breach of the standard of care? Well, you don't. That's the good news, is it is up to the patient plaintiff to prove a departure from the standard of care. If they don't do that, the case is dismissed. If they do that, then the burden switches to you to show how you did comply with the standard of care. And how do you do that? Back to documentation. So your story of the patient's condition and how you treated them is exactly what you need to defend a dental malpractice case. It needs to be timely so it doesn't lose that credibility that we spoke about. Don't finger point. There's nothing a plaintiff's attorney likes better than to see two dentists pointing at each other and saying it was her fault, it was his fault, because then they can just sit back and let the two of you fight it out and decide who's going to pay the plaintiff. So finger pointing is never a good idea. Educating the patient is always a good idea, because a patient who understands the expectations of what's going to happen is not likely to get angered when they do happen. If you have a patient that says something to you that think is particularly relevant or particularly telling in the situation, especially with a difficult patient, it's better to quote the patient than to paraphrase the patient, because if you put it in your own terms, the patient will say, if confronted, I would never have said that. So if they do say something that's noteworthy, use quotes, and then it's verifiably theirs and not yours. So managing the risk of litigation through education, evaluation, and communication. So evaluation, and Deanna got into this. Check to see if this patient is a good candidate for your procedure. Not clinically speaking, but is this patient a good candidate for your procedure? Check their history, screen for risk factors, but also just, is this someone that you're going to be able to work with in the long term? An understanding by the patient, that education of the patient is key as well. That they understand the risks, that they understand the potential outcomes, the time that it's going to take, that there may be some pain along the way. Those are all some important things for the patient to be, to be clear on with the patient. And that leads me right into the second kind of dental malpractice, which is a lack of informed consent cause of action, which is, it's defined by the Public Health Law 2805D. And it's the failure to disclose the risks, benefits, and alternatives that a reasonable dentist would have disclosed to the patient before doing a procedure. That a reasonable patient would not have undergone the procedure had they been told those things, and then they've been injured. It doesn't apply in an emergency, and it doesn't apply to unless it's an invasive procedure. But those that's oftentimes you'll see in a medical malpractice case, you'll have that deviation from the standard of care pled as one cause of action, and a lack of informed consent as a second cause of action. The informed consent one can be avoided by good documentation. It's important to know that informed consent is a non-delegable duty. What I mean by that is the dentist performing the procedure needs to get the consent. It's not something where your assistant can get it ahead of time. It has to be you. You need to make that determination that the patient has capacity to give consent. You need to, if there's an interpreter involved or a parent involved in the consent, assure yourself that this patient is aware of what you're about to do and what the risks, benefits, and alternatives are. If the patient has a family member present for the informed consent discussion, document that, because you can bet that that person's going to be a witness if there's a dental malpractice lawsuit. Document that informed consent discussion on that piece of paper. That's the informed consent, the one that the patient signs. Make it as detailed as you can. One that's generic, they'll say, oh, they've got these for everything in their office. This doesn't mean anything. You don't want it to be generic for a procedure. You want to make sure it says exactly what the procedure is and what the anesthesia is, and then document it in the chart as well. We can succeed on motions to dismiss these informed consent cases if we have the right documentation, but really it's that together, that proof of it, something in the chart and the signed document that the patient signed. Because what the patient's going to say, if it's a lack of informed consent case, they're going to say, I didn't know what I was signing. I didn't understand. They didn't tell me anything. They just handed me the paper and told me to sign it. Well, if you've got it written down what you discussed in 2 different places, that seems pretty incredible, right? So in your note, include the fact that you discuss the risks, benefits, alternatives of the procedure that you're proposing, as well as the risks, benefits, and alternatives, meaning doing nothing being one of those. That the patient was given the opportunity to ask questions and that you answered those questions to the patient's satisfaction. If there's anesthesia involved, make sure that's included as well. And then after all that took place, the patient decided to move forward with the procedure. That's in your note. That is a case that we can make a nice motion to dismiss. An informed refusal is similar, where the patient refuses to have that x-ray you recommend or refuses to go forward with the procedure that you recommend. You want to make sure that they understand the risks of what they're choosing, what their choice means for them, and that should be documented as well. So the devil's in the details. Thorough documentation is the best defense. The dates, times, what you saw, what you said, what you did, all the things, what they said, those are all very important. Any procedures that you did, diagnostics that you did, that should all be documented. Juries believe plaintiffs' attorneys when they say if it's not documented, it didn't happen. So make sure it's documented. Telephone calls, same thing. Make sure those are documented. Make sure your response is documented. If you took the time to take a telephone call off hours, get credit for doing it. If you're undertaking a treatment plan, it's a good idea to go through that and have that in writing with the patient. And you may want to give the patient a copy of that plan. If there's non-compliance with the plan, it's important to document that as well. And it's important to document the fact that you spoke to the patient about that non-compliance and got their assurance that they were going to turn it around. Be very wary of criticizing other dentists' work. It doesn't get you anywhere other than, like I said, that pointing fingers thing that plaintiffs' attorneys love. You have to realize that when deciding whether to take a dental malpractice case, a plaintiff's attorney, the first thing they're going to do is do a request for your records, and they're going to look at the records and they're going to see what story those records tell. And if it tells that there's a contentious problem between 2 dentists, that's a case that they want to take. If it's a well-documented, thorough record, that's not a case that they want to take, because that's going to be a record that's easy to defend. It's also going to be a record that your defense attorney is going to be happy to see, because it is going to be very helpful in the defense of that case. If all else fails and you do need to discharge a patient, it happens. It can be for most any reason, as long as it's a non-discriminatory reason. Okay, so they aren't paying their bill, they are difficult and nasty to your staff, they won't comply with your treatment recommendations, that those are all reasonable bases for discharging a patient. We do recommend that that your written discharge include a 30-day urgent care offer, meaning the patient can come in if there's an emergency for 30 days, gives them an opportunity to find another dentist. And if that's the case during that time, it's up to you whether it's an emergency. It's not up to them. The lapse of time, just because a patient hasn't been back to see you, that doesn't end the relationship. You still have an obligation. So it's a good idea if you're thinking about discharging a patient, do it sooner rather than later, because that statute of limitations starts to run in 2.5 years after that discharge. You don't have to worry about that patient anymore. We have a lot of resources at MLMIC for helping you out with patient discharge and, draft letters for various reasons. So please contact us if you're considering a patient dismissal, and we'll be happy to help. So in summary, the major contributors to litigation: communication, communication problems, bad or no documentation, and disrespectful behavior. A happy, satisfied patient is not likely to sue. Communicate with your patients the way that you would like them to communicate with you. And, all those studies that say sit down, let the patient believe that, let the patient know that you're listening, let the patient know that they're being heard. Those are important things. That kind of relationship is not a relationship that ends in a lawsuit. And if you take anything away from you tonight, what I'd like you to take away is the importance of a good record. It'll discourage the plaintiff's attorney from taking that case. It'll help your defense attorney in the event that plaintiff does find someone to take the case, and it'll be the legal record that it's intended to be for future providers and for you. The second thing is that, MLMIC has a lot of resources. You heard about a lot of them today from Deanna, and please take advantage of them. We're here to help you with the difficult situations, with the everyday situations. We're available in risk management and in legal, so please feel free to reach out to us. And now we're going to move on to a question and answer where we'd be happy to hear from you.
Thank you, Deanna and Nancy. We really appreciate it. One last reminder that you can enter your questions into the Q&A feature, which you will see is at the bottom of your screen. So we do have a few questions. I believe this one is for Nancy. Are dental practices treating adult patients bound by the Affordable Care Act?
So the answer to that question turns on whether or not the dental practice is receiving federal funding. But I'd like to say that even though that means that a lot of dental practices then do not have that obligation, it's key to, the safe and reasonable practice of dentistry. If you or a staff member do not speak the patient's language, an interpreter or an interpreting service is recommended. There's many of them by telephone. They're relatively easy to access. With all that a dentist must communicate to a patient: treatment plan, cost, timing, consent, it is not reasonable to communicate this information to a limited English proficiency patient without a qualified interpreter. The time and cost of defending a dental malpractice lawsuit is far greater than absorbing the cost of an interpreter.
Thank you for that, Nancy. We appreciate it. The next question that we have: how much do I need to tolerate bad behavior from patients? Patients seem to be getting more aggressive with staff and are becoming more threatening and using profanity. At what point can I dismiss them for this behavior?
You want me to take that one?
Sure.
Okay. Well, I know we both mentioned the zero tolerance policy right from the get-go. So if your staff, they feel threatened, either physically or emotionally, you just can't have that effective dentist-patient relationship. So unfortunately, you have to consider, dismissal. And we do get a lot of calls in about this type of thing. People are using profanity a lot more now, and you don't have to tolerate it, and your staff doesn't have to tolerate it. So just don't take it upon yourself to do it. Give us a call first. We can put you in touch with the legal department, tell you how to do it the right way. Nancy had mentioned, letter writing and being able to, give the patient 30 days to look for another provider. So, all these things, all these steps have to be in place before you dismiss the patient. And then you have to think about, that front desk staff, they always get the brunt of it, and then that affects their job satisfaction, and we know that it's difficult to find good people to work. We have shortages across so many professions, so you just want to do what you can to keep your staff happy, everyone safe, and just properly dismiss the patient.
Thank you, Dan. I appreciate that. Next
Mhm.
question. How should we address patients that refuse treatment due to costs?
You want me to do that? Okay.
Sure. I think we can both jump in on this one, Deanna. You want to start?
Sure. Yeah. Like some patients, you have to, like myself, I had to, go to another, dentist, an oral surgeon. There are costs involved, and, patients sometimes just can't, afford it, and, they don't go. And, you just have to be able to, explain to them that, this affects your treatment plan, and you don't want them to come back, months later in more pain or more problems that can't be fixed. So it's very common that people complain about the cost, especially now everything is so expensive. So just being able to to really let them know and document that you have this conversation with them about the problems that can occur if they don't follow your treatment plan. I'm not sure you want to add anything to that
Yeah,
one?
I just a couple of more legal sides to that is that I would recommend, if there is a refusal to get treatment, to go through that informed refusal process where you're explaining to the patient, what the risks are if they don't do what you're recommending, and then have them sign off on the fact that you've fully informed them of that outcome. And sometimes it may be just that you can't continue to treat a patient as much as you'd like to, who's unwilling to move forward with a treatment plan because it's just going to go from bad to worse. And so sometimes non-compliance can turn into a malpractice lawsuit when what you knew would happen has happened. So you want to make sure that's documented, and if you think that that's where the way the tide is turning, you probably want to discharge that patient for non-compliance with your treatment plan.
All right, thank you for that. We have a couple more questions here from the audience, and thank you very much for those questions posted in the chat. Can you discuss release forms when money is refunded? If a patient signs a release form, does that mean they can never sue?
So generally, yes. If an appropriately drafted release drafted by an attorney is given in exchange for a payment of money, that is generally enforceable. And that is the reason you want to get a release if you ever settle a case. That's what prevents the patient from coming back and saying, well, now I have another, few symptoms that I'd like a little extra money for. So it's very important, if you are going to enter into a settlement or a refund situation with the patient, that you do get that release. There's a lot of factors that go into whether or not that's the best option. And, we have attorneys available, every day to, go through that with you, explain the benefits of going the release refund, way versus, having MLMIC look at it in terms of whether or not that, it's a case that should be investigated or if it's a case that should be denied. So I definitely recommend that you call and speak with an attorney. We're not going to tell you what to do. We're just going to share with you all your options, and then you can make an informed choice.
Okay, thank you for that. Got a couple more here. With respect to timing of discharging the poorly behaving patient in the middle of an uncompleted treatment plan, i.e. implant restoration, for example, what is the dentist's legal obligation to avoid abandonment of the patient?
Absent some really, really disruptive conduct, it is your obligation to finish a treatment plan before discharge. So if the patient's in the middle of a course of treatment, you should finish that course of treatment, and then as soon as it's done, do your discharge then. Because if you're in the middle of treatment, the patient's got stitches in their mouth, it's not the time to send them a discharge from care. Finish that off and then move forward. There's no like black and white what is patient abandonment, under what circumstances. It's a matter of what the circumstances are. So if you have an abusive patient and you're in the middle of the course of treatment, it may be a case where that has to happen in any event, or the treatment needs to be done at a different location to preserve the safety of the office. But it's really fact specific. So again, it's one of those things. If you're facing that situation, give us a call. We'll talk through it, come up with the best answer and the best timing for that discharge, and keep you, away from any issues with the Department of Education.
Okay, thank you for that one. Got a couple more here. What should you do if a patient refuses to sign a refusal of treatment form?
You should do your best to document it yourself. And that is not uncommon, because if someone's refusing to sign, if someone's refusing, your care recommendations, not surprisingly, they're also being uncooperative about documenting it. I think that's a pretty good indication that that patient, may be needing discharge. But more importantly, it's something where you want to document it. So much like I talked about, you have the informed consent that the patient is signing, and then the office chart that you're preparing. This would be the office chart that you're preparing, explaining, what it was that you proposed, why you proposed it, what the patient's response was, in their words, that the patient refused to sign, that they were refusing the care. If they gave you a reason, put the reason down. And then that you told them that what are the possible outcomes here for their refusal, and that they still refused to move forward with the recommendation. That's your best protection in that situation.
Good, thanks, Nance. Appreciate it. It looks like we've answered all of the questions that we've got so far. And as you see, the program evaluation is up on the screen. So we're about set. We would like to once again thank the New York State Dental Association for partnering with us to bring you tonight's webinar. We would also like to once again thank all of our presenters for bringing this important information to you. And certainly we want to say thank you to the audience, both for your time and for your commitment to patient safety. Please again, be sure to visit our new standalone dental website, milmic.com/dentists. At this time, the webinar is over. Thank you for joining us, and have a nice evening.